A very warm good morning to all. I'd like to thank the scientific committee, the organizing committee of this RADCON, the first BIMSTEC conference. I'd like to welcome all the distinguished international faculties, the national faculties, and all the participants here in this RADCON. First of all, I'd also like to introduce my mentor, Dr. Deepasri. She's the gem of liver transplantation management through minimally invasive in Chennai, Dr. Rella Institute. And she's one of the best IR who does very minimally invasive in all liver transplantation. Let's all cherish Dr. Deepasri. And I'm here because of her. So key to successful liver transplantation, the heroes behind the curtains, of course, the radiologists, because they give the initial diagnosis and the interventional radiologists take their part for the management of the complications. I have no disclosures to this presentation. So looking at the transplant patients are different, and most patients have the benign disease and are potential for long-term survival. Resources that's liver and financial are often limited. So every effort must be made to salvage the graft, and is the challenge for the interventional radiologists and surgeons as well. Immunocompression alters both response to infection and healing process in these patients. So this is the basic liver anatomy. All the radiologists should also know. In the orthotopic, whole of the liver is a transplant, and all the hepatic artery, portal vein, and the biliary tract is anastomosed. In the living donor liver transplant, the half of the liver is transplant in split fashion. So orthotopic liver transplantation, systemic inferior vena cava, whole liver in cavocavastomy. In adult, piggyback liver transplantation, hepatic venous in split. So this is the schematic diagram of the transplant anatomy of the very vasculature and the biliary system. So orthotopic liver transplantation, all anastomosis are potential sites for stenosis. So if it's a vascular anastomosis, it may lead to stenosis or thrombosis. So what are the complications usually presents to us? The graft failure. So we can just do a percutaneous liver biopsy and diagnose. If there's ascites, we can approach to the transjugular approach, and then we can take a biopsy from the right hepatic vein branch. And vascular, if there is vascular complications like hepatic artery stenosis, most common is 2 to 12%, and other complications are arterial aneurysm, portal vein stenosis, hepatic vein stenosis, and IVC stenosis. Biliary ischemia, strictures, bile leak, and bilirubin are other complications are hepatic abscesses. So how do we diagnose these complications? By ultrasound as an initial screening modality done by our radiologist, who helps us in the diagnosis all the complications. And multi-detector CT and CT angiography are done in selective cases to further delineate the complications. And MRI and MRCP is done for problem-solving cases, for biliary strictures, for abscess strictures, and other biliary complications. So frequency, this is the frequency down from biliary is the most common, going down to the hepatic artery, portal vein, systemic venous, and vascular complications of 9 to 12%. So here, going back to the basics of the ultrasound, Doppler findings, post-liver transplant, this is the real cases. And then in this, the hepatic artery, we can see anterior to the portal vein, and we can see the rapid systolic stroke with continuous forward flow in the diastole, and showing the normal resting index of 6. This another hepatic artery supply, and then this is the CT scan, coronal and reformatted images showing the celiac hepatic arterial supply, and the right and the left branch supply. So this is the post-operative on the liver transplant patient on Doppler day 4, showing the normal Doppler of the hepatic artery. This is the day 6 Doppler's finding. The hepatic artery, also the size has been up to 7.4 mm. And this is the day 10 showing the hepatic arterial normal flow with the size increasing up to 13.6 mm. Hepatic artery stenosis. is one of the most common complications we encounter, and it occurs in more than 4 to 11% of all transplant recipients. Hepatic artery stenosis is divided into early onset, less than 30 days after transplant, and late onset, more than 30 days of transplantation. So how do we confirm? We confirm by the CT scan. So we can see there's no flow of in the hepatic arterial circulation. And then this patient was now taken into the cath lab, and the femoral puncture, and then we can see there's no supply to the hepatic arterial system. And then intra-arterial thrombolysis was done in this patient using the low molecular weight heparin. And then subsequently, we can show the improvement in the hepatic arterial branches in the periphery. So this is also the case of the hepatic arterial stenosis, and then we just the next day we did the balloon angioplasty was done, and then we can see much beautiful opacification of the right and left hepatic arterial branches. This is also the hepatic arterial, and following the Doppler ultrasound done by the radiologist, and shows the normal hepatic artery waveform, and then the patient doing good. So hepatic artery stenosis usually occurs at the site of anastomosis within 3 months after transplantation. If left untreated, it may lead to heart ischemia, biliary strictures, sepsis, or even the graft loss. So cholangiographic abnormalities are present in more than 60% of the cases, and it presents as non-anastomotic biliary strictures, biliary obstructions secondary to sludge or debris. So arterial stenosis color Doppler study usually shows the peak systolic velocity of more than 200 meters per second, and our focal increase in the peak systolic velocity of greater than 3-fold is suggestive of stenosis. That is more than 50% of the stenosis of the artery. An increased acceleration time of more than 0.8 seconds, and restive index of less than 0.5. So first, we have to, for this case, we have to percutaneous transluminal angioplasty should be attempted, and arterial stents should be placed for unsuccessful dilatation. Despite the successful endovascular technique, the majority of patients might still require retransplantation, as cited by Orens et al. In JVIR in 1995. Hepatic artery stenosis, percutaneous luminal angioplasty, as Mondagrone, RS et al. And transplanted cited that the technical success is up to 80 to 90%, and physiological improvement in 40 to 60%, and retransplantation in these patients are often frequent. So hepatic artery stenosis, we do the stenting, and then we put the stent, and then we see the normal flow. And hepatic artery stenosis, the stenting results are very significant number of patients are lacking, and then patency up to 25 months have been reported, as cited by Warwick D. et al. In JVI in 1994, and the other Katas et al. And Steen M. et al. And Cortreno R. et al. In JVIR in 2002. So hepatic artery thrombosis, we can see the failing defect, and then intra-arterial thrombolysis can be done with low molecular heparin, and shows the good flow within few minutes or few hours after the intra-arterial thrombolysis. So hepatic artery pseudoaneurysm, focal bulge of the contrast, and then we can see the images of the pseudoaneurysm. This can be well managed with the covered stent. Portal vein stenosis, we can see the filling defect, and then we can puncture the peripheral branch of the portal vein, just reach the portal vein, and the thrombus, cross the thrombus, and then we can just aspirate, or also we can do the intravenous thrombolysis, and then we can get the good flow. So these are the live cases done by Dr. Deepashri, and I was lucky to be there at that same time, and I was assisting those cases as well. So this was the case of the first week Doppler showing significant increase in velocity of 360 centimeter per second in post-anastomotic segment of portal vein, and low velocity of 36 centimeter per second in peri-anastomotic segment. However, intraoperative Doppler was normal in this case. And we can see the narrowing in the CT scan as well, in the coronal and referment images. Also in the angiogram, we can appreciate the narrowing. So portal vein stenosis, then peripheral puncture, and then plasty was done, and then improvement in the portal flow. CCT and coronal MIP was done, showing the significant portal vein stenosis, and there was still the persistent gastric varices was also noted in this case. Contrast CT scan was done to confirm the portal vein stenosis to rule out the cause of continuous. There was high flow volume drain, more than 2 liters per day in the 4th post-week operative day. So portal vein stenting was planned at the end of the 4th week, and the significant gradient of more than 10 millimeter of mercury was noted across the stenosis. Balloon dilatation and stent places was done of 8 mm into 40 mm, and tract was embolized with coil. And post-stenting, immediate reduction in the drain volume was observed from 2 liter to 300 ml per day, and then stopped within a week. Significant reduction in the portal vein velocity of 89 centimeter per second was seen after the stenting. So patient was improving. And post-stenting, within a week, patient developed again the biliary leak. So the team, Dr. Deepa and our team, we try to negotiate the leak, but failed, for which an external drain was kept. After 2 weeks, there was persistent leak. So we failed to negotiate the leak and planned to leave an external drain for 2 more weeks. After 4 weeks, we were able to cross the anastomotic leak, and then we put an internal external drain. And patient still remains on follow-up, and patient is doing well. So thanks to all the team who has done the wonderful job to save this graft of the patient. Portal vein stenosis, thrombosis, incidence less than 2%, and its most common cause is from the technical problems, usually from the surgical complaint. This usually occurs as a vessel. Sometimes the diameter of the vessel misalignment, or there is a caliber of the anastomous vessels, or stretching of the portal veins at the anastomotic site, previous portal vein surgery, or previous thrombosis. So if thrombosis occurs within 1 month of transplant, hepatic dysfunction and failure may be observed. If stenosis and thrombosis occur late, sequelae of portal hypertension that occurs as bleeding, ascites, and encephalopathy are usually the presenting symptom. And diagnosis can be just made by a clinical surveillance ultrasound. So portal vein stenosis, thrombosis, the therapy, we can do acute thrombolysis can be treated by fibrinolytic therapy and mechanical thrombectomy. Less than 20 cases has been reported with success of 80%. As cited by Seru Kuri R. et al., transplantation in 1998, Bakarani U. et al., transplantation in 2001, and systemic portal venostenosis, portal venoplasty can be done, and stent can be successfully placed. Portal vein stenosis, again, we can see the collar Doppler showing focal aliasing in the anastomotic segment of the portal vein, and the coronal image also showing the same findings. So I'll just skip this. And then ballonplasty was done, and then the patient has a normal flow there. So systemic venous complication, IVC, and other hepatic venous and combined IVC and other are usual complication. If there is suprahepatic or hepatic vein in split liver transplantation, give rise to Budd Chiari with ascites, portal hypertension, and mild hepatic dysfunction. Intrahepatic IVC stenosis lead to lower limb edema, and treatment is portal venoplasty and stenting. So this is the case here. IVC stenosis, ballonplasty is done, and then normal flow is restored. So IVC thrombosis, we can see the defect, and then the stent has been placed over there. Non-anastomotic complications are biliary infective hematoma, so collections with significance less than 25%. Conservative management for small non-infected can be done. Ultrasound and CT guided drainage of the infected collections, myeloma, and can be done. If there is a blocked tube, we can remove the tubes and manage it accordingly. So different types of catheter we have to use according to the viscosity of the fluid, whether it's thick or thin. From 8 French, we can go up to 14 French, and then just drain the collections, or minimal small focal collections can be done as a single puncture aspiration. Hepatic venous stenosis shows focal aliasing in the collar Doppler ultrasound as done by the radiologists, and then hepatic venoplasty can be done. So non-anastomotic complication, biliary infective hematoma can be done. So biliary complications, usually 25% most common complication. Biliary complication include stenosis, fistula, obstruction, stone formation, dysfunction of the sphincter of Ori, and recurrent biliary disease. So choledochostomy, that's duct-to-duct anastomy, prepared anastomosis by the surgeon, preserves sphincteric mechanism, allowed retrograde and bowel surgery. So colidoco other is duodenostomy, but this cannot be performed if there is cholangitis, biliary atresia, duct size mismatch. Okay, I'll just skip it.
You have to wrap up.
Okay, just I'll wrap up with the other strictures. So take away message. The overall success of liver transplantation program is strongly correlated with the ability of radiology and interventional radiology expertise. IR plays a critical role in both pre and post liver transplant care, and radiologists are also heroes because they give us a definite diagnosis, and we get the patients from our radiologist colleagues, and then we treat them accordingly. Common procedures include liver biopsy, PTBD, arterial and venous ballonplasty, and stenting. Transplant patients do not have the same immune and healing response, and as they are non-compromised patients, most likely they are the patients who are most likely to leak, most likely to develop infections. However, reoperations by the surgeons in these populations for anatomic revision is awful difficult, and they don't want to do it as well. So therefore, aggressive percutaneous approach is often oriented. There's the role where the IR comes to play, and we can do a wonderful job. Early use of IR can manage complication and optimize transplant outcomes, and we can move forward. Thank you for your kind attention.